So my name is Osei Kankam. I'm a respiratory consultant here at Conquest Hospital. This tutorial is on two topics, lung cancer and pleural effusion. What I've tried to do is I will set out a few learning objectives. So a short introduction, we'll talk about risk factors, symptoms, diagnosis, investigation, and management, and basic things that we are supposed to know. There has been a lot of new developments in the management of lung cancer, so I'll touch on some of those things because in your practice you come across more and more of these things. So lung cancer is one of the most common cancers in the world, usually associated with smoking. The lifetime risk of men developing lung cancer is 1 in 14 and 1 in 19 in UK women. And the risk is also for those who are called passive smokers. So I said I'm going to talk about lung cancer and pleural effusion. The learning objectives are I've outlined earlier on. I talked about the fact that the risk of developing lung cancer has a close correlation with people who smoke, and it extends to non-smoking spouses of heavy smokers. Lung cancer is one of the most common cancers in the world and represents about 12% of all cancers. Unfortunately, in real life, it's sort of relegated far behind breast cancer and things like testicular cancer and pancreatic cancer because it doesn't have a strong lobby. And the general view is that you did it to yourself. And so, unfortunately, that's what's happened. But recently, there has been a lot more research going into lung cancer. The risk factors I've talked about, the major one is smoking. The other factor associated with lung cancer development is asbestos exposure. And this is with all forms of asbestos. Asbestos in the UK is currently banned, and whatever asbestos is around is asbestos that was installed more than 10, 15, 20 years ago. And the risk of lung cancer appears 20 years after exposure. So most people will not remember their exposure. Ionizing radiation, which is all forms of radiation, ranging from chest X-rays to CT scans, and in places where there's very high air pollution from fossil fuels, etc., risk of lung cancer is high. And so that's why it's very high in industrial areas. The main presenting complaints for lung cancer are cough, breathlessness, weight loss, hemoptysis, which is coughing up blood, chest pain or voice hoarseness. And voice hoarseness is usually due to what we call a recurrent laryngeal nerve palsy, where the left vocal cord becomes paralyzed. But 90% of patients I see with lung cancer have no symptoms at all, and usually will present with a GP with lethargy, and a significant proportion is also found incidentally. So this is an insidious cancer. Examination is usually normal because the lung is a large organ, and it requires sometimes luck that the cancer develops in a place where you're more likely to have hemoptysis or have pain. Otherwise, the presentation will be rather without any symptoms, physical examination findings at all. The findings I talk about, hoarseness, lymphadenopathy, wheeze, etc., will be associated with the presence of the cancer for a significant period of time. And essentially what we are seeing here are the complications of cancer being present rather than the cancer itself. The investigations we will normally do include a full blood count, which may show anemia, White cell count may be elevated if patients have pneumonia. The other things you've heard about are things like hyponatremia and hypercalcemia, and these are what we call the non-malignant manifestations of cancer. And then LDH levels may be raised and platelet counts may be raised. Now, I have included hyponatremia and hypercalcemia here because they are the other manifestations of cancer that you would be aware of. And I think some of those topics will be also taught in endocrinology. The hyponatremia could be due to syndrome of inappropriate ADH secretion. Hypercalcemia may be due to ectopic PTA secretion or due to bone metastasis. And then there are the other things that you will hear of, such as HMPOA, which is the osteopathy that you can have with cancer. Now, how do we diagnose lung cancer? We've talked about history and physical examination. The diagnostic test we normally do a chest X-ray, and then we have to do a biopsy to confirm the histology. It involves a bronchoscopy, which will be the internal inspection of the lungs, a needle biopsy, which could be a percutaneous needle biopsy, or sometimes the location of the tumor is so deep that you need a surgical procedure to get it out. We do all this, we would do a CT chest and abdomen, and we call it a staging test because it allows us to determine whether the cancer we are dealing with is localized to the chest or whether it is spread beyond the origin. A bone scan, these days we don't use much, but occasionally it may be necessary because you want to see whether the bone is affected or not. Bone marrow aspiration, we don't use that much these days because we do something called a PET scan, where FDG avid glucose is injected and a CT scan taken. And then where there is high avidity, we can tell whether there is metastasis or not. So this is a CT PET, so that's the normal CT, that is the PET, and that is the high avidity you see. And so this is somebody with cancer that is very close to the chest wall. Now, because I have mentioned surgeons, I've mentioned bronchoscopy, I've mentioned the fact that we need specialist treatment, etc. Lung cancer is not managed in isolation by a single doctor or nurse. The usual practice is that it's managed by a multidisciplinary team of doctors, nurses, and other physicians. So a typical team will have a radiologist who will go through our CT scans and X-rays, an oncologist who will supervise specific anti-cancer treatment, chest physicians like me who would usually be involved in managing the diagnostic pathway and some of the complications, a thoracic surgeon where surgery is needed, a specialist nurse to support the patient through the whole journey of diagnosis to treatment and follow-up. We sometimes need palliative care specialists because some patients are diagnosed quite late in the disease trajectory. And then on top of all this, you need a patient pathway coordinator who will make sure that all these people are working together. Our multidisciplinary team meeting in the past used to involve a 4-way video conference from sites in London, Brighton, Hastings, Eastbourne, and sometimes from Chichester. So all these people come together to make a decision about patient care. In real life, this is what we do, and you would very soon become aware of. So this is what I call the lung pathway. Typically, it can take up to about 50 days to make a diagnosis of lung cancer. A patient is referred, we review the X-rays, we do a CT scan, we decide what investigation is needed, and all this can take about 2 weeks. And if it's a bit more complex, then we do more complex tests along the way. And then we have a multidisciplinary team meeting. For majority, within 2 weeks to 21 days, we can come to a diagnosis. but for some people it's a bit more complex. But along this pathway, if you come to a diagnosis and what we call a staging, then you get to your treatment as is appropriate. There are two main variants of lung cancer. We have small cell lung cancer, which is about 10 to 20%, and then the rest is non-small cell lung cancer. We have this distinction because the treatments vary significantly. Generally, small cell cancer responds very well to chemotherapy, but it has a poor prognosis. Median expectancy is about 6 months, life expectancy, I mean, after diagnosis. The other forms of lung cancer are an adenocarcinoma, squamous cell carcinoma, large cell cancer, and then a combination of squamous and adenocarcinoma. And once we've had a histological diagnosis, we do something called a staging. Now, the staging is what determines your prognosis and what treatment we will offer you. This is the staging that we used to use until fairly recently, which has been changed. Essentially, is based on the size of the tumor, the degree of lymph node involvement, and whether there's metastasis outside the chest or not. So if you can imagine, if there's somebody with a T4, which is infecting, which is a large tumor with lymph node involvement across both sides of the chest and metastasis to adrenal gland, then they've got what we call stage 4 disease. Outcomes for these patients are not very good. Whereas if all you have is a 3-centimeter lesion, then the outcome is very good because you can have specific treatment to remove the cancer. Small cell used to be staged into limited stage and extensive stage, but we now use one staging for all, both lung, small cell and non-small cell, and it's the International Society for Lung Cancer staging. It's a very busy slide. It's very similar to this in that we have T1A, T1B, T1C, whereas in the past was T1, T2, T3, T4. These definitions allow us to decide who has aggressive surgery and who doesn't. And then up here, you see the lymph node staging. So stage 4 is somebody with metastatic cancer. Stage 1A is somebody with a small tumor, which we can do a lot about. And then in terms of the treatment, this is the treatment algorithm for lung cancer. So we carefully have to stage. We have a histological diagnosis. We talked about PET scan. We talked about PET scan and EBUS, which is an endobronchial ultrasound, which is a form of bronchoscopy. Recently, we do something called molecular analysis, and I'll talk about that in the next few slides. So going back, stage 1 is a very early stage cancer. The treatments include surgery, which you remove the tumor, osteotatic radiotherapy, which has other names such as cyberknife. So all you're doing here is giving very, very, very strong radiation to the tumor to completely get rid of it. Stage 2 is not so good. You do surgery and you add other things such as radiotherapy or chemotherapy to it. Stage 3, what you are given here is treatment that is not curative. So 1 and 2, you can offer curative treatment. 3, you are supportive. Stage 4, if you have PS's performance status, if you are self-caring, etc., then you can be offered some chemotherapy. And stage 4 is very little that can be done. But now, current developments tell us that there's something more we can do. The patients are fit. And then obviously there are people who are very poorly, can hardly get out of bed and have to be offered palliative care. So this is the treatment algorithm for cancer. The treatment options have improved in the last 50 years or so. When I was training in the mid to 2010, late 2009, 2010, etc., all we had was a bit of chemotherapy and a few targeted treatments. Now we have different forms of chemotherapy, we have targeted treatments, and we also have immunotherapy. And so we've moved from what we call traditional way of doing things with you either had surgery, you either chemotherapy or radiation, to what we call targeted treatment, where if we determine that if a certain molecular change on your tumor, we can target treatment for you as a patient. It's called more precision medicine or translational medicine. And then the immunotherapy is also quite interesting. Let me just see these slides. It's okay. So instead of seeing non-small cell cancer as a single disease, in the past that was the originally what we thought, and then we moved to adeno and squamous, and now we can look for specific molecular subsets on the cell wall of the tumor, and these are the things we look out for. And each of these mutations, if you have each of these molecular mutations, specific treatments can be targeted to your cancer. And these are the targeted therapies so far available to treat adenocarcinoma. 10 years ago, there was only a single one of them called erlotinib. And if you look here, EGFR, ALK, MET, HER2, ROS1, BRAF, etc. So we are learning more and more and more about what we do with lung cancer. So it's no longer a Cinderella disease. And then the other, what we call immune checkpoint inhibitors. So the immune checkpoint is where your T cell identifies an abnormality, and then it has to log onto the cancer cell in order to release cytokines to kill it off. Some of these have developed checkpoint inhibitors where the T cell becomes ineffective. But if you have a PD-L1 inhibitor, then it locks onto the checkpoint and allows the T cell to work. So essentially, you're enhancing your immune system to be able to fight cancer, and that's what immunotherapy is all about. And this is what we do. So even if people very, very poor staging, if you're able to get the right testing for them, you can give something called pembrolizumab, and it makes a wonderful difference to people's outcomes. So these are the future treatments for lung cancer. So I've talked about how we diagnose cancer, how we stage it, what the presentation is, and what the future holds. And I'm mentioning these because by the time you start practicing, this would be the more common way of managing lung cancer. I'll finish lung cancer by just giving you two case scenarios. SB, patient is called SB, smoker of 50 pack years, 20 cigarettes a day, every day for 50 years. Persistent cough, but no alarm symptoms, so no weight loss, no hemoptysis, no chest pain. Good effort tolerance, performance status was good, so fit and active, and had a clear chest x-ray. Somebody thought, oh, if you're coughing and you're a smoker, we might as well get an x-ray done on you. So this is an x-ray. This is what the x-ray showed. So this is a lady, so there are breast shadows here. Very bilateral changes and some rounded opacities on both sides of the chest. And this is what a CT scan shows. So there's a tumor here and a tumor there. So she had a stage T3, M3, M1E bronchogenic cancer. Sorry, the last bit didn't come in. In her case, the next steps in her management would be due to get a histology, do a molecular testing, and get targeted treatment if that's appropriate. In the past 10 years ago, we would have offered her palliative chemotherapy if she was strong, or very little at all, and patients would have faded away. But with molecular treatment, some patients live for 18 months, even at this stage of cancer. And what we are interested in is quality of life and not necessarily quantity of life. By that I mean we are aiming to give people a good quality of life, to lead reasonable life and reasonable day-to-day activity, as opposed to prolonging life for the sake of doing that. And that's why you need people who are fit to maintain their fitness. I'll give you another scenario. It's a smoker, 40+ years. He had symptoms, exertional breathlessness, he had hemoptysis, and he had had several courses of antibiotics without improvement. His GP then performed this chest X-ray, which shows an abnormality at the bottom of the right lung. We had a CT scan, which shows what we see here is collapse. This part is the liver. It's collapse of the right lower lobe. He had a bronchoscopy, which showed that there was an bronchial lesion in the middle of the right bronchus, verifiable mucosa. The biopsy showed differentiated squamous cell carcinoma. And then we staged him further, and he had a PET scan, which showed that he had a very bright tumor here. And then the final staging for him was T2 N0 M0 squamous cell carcinoma. He had a performance status of 1, which means he was fit. He had good lung function, which is what I've documented here. And so we referred him to surgery, because what he was is giving treatment with a curative intent. So this is his scan, his chest X-ray before the operation, and this is his chest X-ray after the operation. Now I'm going to ask a question here, and please feel free to tell me what procedure do you think was performed? Please shout out your answers.
Lobectomy.
Lobectomy, okay. Anything else? Okay, so what they've done here is he had something called a pneumonectomy. So they removed the whole of his right lung completely. A lobectomy is when you remove a section of the lung. So if it's right upper lobe, you take the right upper lobe, but it's right upper lobectomy. Middle lobe, right middle lobectomy. So what he had is a complete removal of the right lung, because the location of the tumor was such that if you just took the tumor away and its location, you may leave tumor remnants. So this is completely taken out lung, and the trachea has moved to the side of the lung was taken away, and the empty space is filled with fluid. So he will operate on one lung. Right. So just to summarize, we've talked a bit about epidemiology of lung cancer. Presentation, majority will have no presenting symptoms, but I also alluded to the fact that you may have symptoms of the complication of the cancer at the time of presentation. Investigations, we aim to have a histological diagnosis and stage, because that is what determines what treatment you offer. Treatment options traditionally was surgery, chemotherapy, or radiotherapy. Now there is a lot more we can offer because of improvement in molecular testing and targeted treatment. And then I've also talked about a few clinical cases of patients I've seen recently in clinic. Do you have any questions on lung cancer? I think I'll pause for questions.
Looks like you can move on, Osei.
Sorry?
I think it looks like there are no questions, so you can go to your next topic, I guess. This is Geeta.
Okay. Any clarifications? No. Okay. Okay, so pleural effusions was the next thing we were going to talk about. So our learning outcomes here, we'll do an introduction, we'll talk about symptoms, diagnosis, further investigations, and then management. So essentially, if you have excess fluid in the pleural cavity, it's usually resulting from an imbalance between the normal rate of pleural fluid production and absorption, or both. If you're producing too much or not absorbing enough, then the excess fluid can collect. It's estimated that there are about 200,000 in the UK a year of cases, and it's a very common presentation when you're on the medical wards. There are more than 50 causes of pleural effusions, and there are a lot of mnemonics that you all know. What we want to know is whether it's a transudative or an exudative effusion. I think I missed out a word there. Now, there are many ways to approach the classification or description of pleural effusions, and I'll just try to go through some of them, because we look at the first one we look at is whether it's an exudate or transudate. This is when you have a sample of the fluid, you try to determine whether the protein concentration and the LDH, which is lactate dehydrogenase concentration in the fluid, is greater than 30 or 200 respectively. That shows you that the effusion is likely to be due to inflammation, malignancy, or infection. That's an exudate. Operative word is 30 grams per liter of protein. And then the transudate is usually due to systemic illness, usually cardiac failure, which would be bilateral, renal failure, such as nephrotic syndrome, where you lose albumin, or hepatic, where you have also a lot of fluid building up subcutaneously, both in the peritoneal cavity and the pleural cavity. So the commonest causes of transudative effusions are hepatic, cardiac, renal. The commonest causes of exudative effusions are inflammation, malignancy, and infection. And for each of these, inflammation, you'd find 10 causes, malignancy, 50 causes, infection, many causes, major one of them being pneumonia. I've used the word parapneumonic effusion and empyema, and I'll explain that further in a few minutes. We also have this very important criteria called the Light criteria. And the Light criteria just allows us to be a bit more precise in identifying those who really have a transudate or an exudate. And the reason is generally that when we have an exudative effusion, we get a bit worried because it could be malignancy or it could be infection that we are not treating properly. So we are very, very, very worried when we come across an exudative effusion. This is a good summary slide that I found, and I think it explains it all very well. The fact that a transudate is due to the things we've talked about, and an exudate is due to pneumonia, cancer, TB, etc. The causes of malignant effusions, which is malignant perfusion because of cancer, lung cancer forms 30%, a third of them. The rest are breasts, can metastasize. Unknown, we sometimes find effusions where we don't find a cause. Lymph nodes from lymphoma, mesothelioma, and then 6% ovarian and 10% is unknown. The other types of effusions that are important, chylous fluid due to blockage of the thoracic duct. It's very milky looking fluid, and then when we test for triglycerides in that fluid, it's very high, and it's usually because of blockage in the thoracic duct. And then empyema means collection of pus. It's usually as a complication of a pneumonia. Now, the effusion due to a pneumonia would usually start as a very serous fluid, which we call a parapneumonic effusion. And then as time goes on, it becomes invaded with more bacteria, more white cells, and becomes PASI, and that we call an empyema. In between the parapneumonic effusion and an empyema, you can have what you call a complex parapneumonic effusion. So I've talked about transudate, exudate, and the causes of transudate and exudate, and talked a bit about malignant effusions. The other thing I like to talk about is bilateral and unilateral. So unilateral is one size, bilateral is both sides. Unilateral effusions are usually due to cardiac, renal, hepatic. So essentially, if we have an X-ray where the two effusions on both sides, the first thing you think about is this is likely to be a systemic problem. But if it's a unilateral effusion, then it's usually due to acute infection or malignancy on that side of the lung. Bilateral effusions are usually transudative. Unilateral effusions could be transudative or exudative, but are usually exudative. So the important point for patients with effusions, we want to know the severity, duration of breathlessness, cough or chest pain, because we've looked at all the 50 causes of effusions, and you have to be thinking about these things when we are examining patients. Fever, sweats, or weight loss. So fever, pneumonia, sweats, TB, weight loss, TB, cancer, recent injury to the chest or interventions to the chest. It can be a hemothorax, which is blood in the chest. Recent illnesses related to the chest, again, pneumonia. Recent hospital admissions or operations, cardiac surgery, you can develop an effusion after that. History of malignancy, because we know that malignant effusions can happen from any part of the body. So it could be gut, it could be ovarian, it could be breast, it could be testicular, or active malignancy. And then we think about exposure to TB. The other things is full occupational history, because we want to think about asbestos. We want to know whether they work directly with substance or they were exposed to it, because that increases your risk. We want to know what their tobacco smoking history is. After written tobacco smoking, but we don't, I mean, obviously people smoke a lot of other things. There are drugs, certain drugs can cause pleural effusions, nitrofurantoin, etc. And then we have to assess them for whether they have cardiac failure, hepatic failure, or renal failure. So the assessment of pleural effusions is mainly going back to think about the causes, marry the history of the causes, and then it gives you an indication of what the best investigations are. So on the right-hand side, sorry, on the, what do you call it, X-ray A, you see arrows at the bottom of the lungs on both sides. So that's a bilateral effusion, small bilateral effusions. B is a unilateral effusion, which is sort of halfway up the chest on the left-hand side. C shows you what we call, quote unquote, a whiteout. So the fluid is accumulated and filled up the whole thoracic cavity on the hemilateral side. And then D is what we call a loculated effusion. So you can see 3 different menisci for the effusion. So all these are forms in which a pleural effusion would present. So this one could be most likely to be a transudate. This likely to be a transudate, but the description, if we find that it's a transudate, would be that this one, for example, is a left-sided unilateral exudative effusion, and then we try to find a cause due to pneumonia, due to malignancy, due to rheumatoid arthritis, for example. So that's how we assess pleural effusions. What would the GP do? I hope this projects very well. Essentially, the GP, if they suspect a pleural effusion, will get a chest X-ray. and determine whether it's bilateral. If it's bilateral, then they go along investigating for the things we've talked about. If it's unilateral, then they would normally send them to a respiratory clinic, where we'll do an ultrasound scan. We'll perform something called an aspiration, because we need to take a bit of the fluid to analyze, to determine whether it's a transudate or an exudate. And then we'll send the samples for microbiology and cytology. And then if we need to do any further specific tests, we do that. So, and these are some of the tests we do for pleural effusion. We do the biochemistry to look for LDH and protein, because that allows us to say whether it's a transudate or exudate. Microbiology to check for sensitivities. Cytology to look for malignancy. Sometimes in the emergency department, somebody comes in with effusion. We may, if it's not passed, check the pH, because the pH is very acidic. Then that is less than 7.3, then it will tell us that there's active infection going on in the pleural fluid, and point to a parapneumonic effusion. Glucose is low in infection and also low in rheumatoid effusions. We can look for acid-fast bacillus. We can test for triglyceride and cholesterol if we think it's a chylothorax. In patients with pancreatitis who develop an effusion, you can test for amylase, or patients who've ruptured the esophagus and caused an effusion, a condition called Bohr-Harvey syndrome. You can test for amylase. And if there's blood, you can check the hematocrit. So the few tests we can do in the pleural. So, and the other test we do is we do a full blood count. Apart from the chest X-ray, we always like to do an ultrasound scan to real life ascertainment of the effusion. We'll do an echocardiogram if we think there's heart failure, and then we'll do a CT scan to look at the lung in a two-dimensional fashion and ascertain whether there's any pleural abnormality causing the effusion. And I've talked about checking the pH and the Lyse criteria. Occasionally, we have to do biopsies of the pleura based on the CT scan, and then we do things called a thoracoscopy, which is using a scope to look into the thoracic cavity, the pleural cavity. This can also be done as a major operation this is done under sedation. The VATS is done under general anesthesia. And then you can insert 3 or 4 ports, allow you with a flexible scope to look throughout the pleural cavity and take biopsies if necessary. And I just wanted to show you an image of somebody who had a pleural effusion up here. This is the chest X-ray. And then they had a chest drain inserted to drain out the fluid. And now they've had a CT scan, which looks at the pleural cavity. That's the heart in the middle, the liver below, diaphragm here, and the chest drain going in there. Now, specific management of effusions, we need to manage the breathlessness. So if patients are very obtunded and the effusion is large, and the benefits, the risks of attempting a procedure outweighs the benefits, then we can sometimes just manage breathlessness. But otherwise, we'll do an aspiration. A diagnostic aspiration is just to take a bit of fluid to analyze to see whether there's transudate, exudate, whether it's infected, and whether cytology is. A therapeutic aspiration, for example, for this one, if instead of putting a drain here, we could have had a special device to drain off maybe 1 liter, 1.5 liters of fluid, and then take the device out. That is called a therapeutic aspiration, and is to relieve breathlessness. And then finally, we can put in a drain if there's a large volume of fluid to do that. But an important thing is to find out why the effusion happened in the first place, and that's why we go through all these steps, trying to look for the reason why the effusion happened. And then sometimes, just like we have people with catheters for urinary problems, we can occasionally insert a long-term indwelling pleural catheter, especially for cancer patients. You keep taking the effusion out with a aspirating kit or drain, and the effusion keeps recurring. And then what we do is we place a catheter in there, and the patient can do their own pleural aspiration in the community. This is something I've included because it's increasingly becoming common practice. And the advantage of this is that patients can manage their own care, lower risk of infection, and is usually well received and well tolerated. This is Mr. AR. He presented originally with acute dyspnea. He was aspirated on the 21st of February, 25th, 3rd of March. So he just kept coming in and over and over and over again. And at one of his, we eventually did a thoracoscopy and diagnosed an epithelial mesothelioma. And then what did we do? We inserted a tunnel drain, which you can see better here, drain that goes into his chest. And since it was inserted a few months ago, so he's never been admitted to hospital, and is managing his effusion in the community. And this does not stop him having his chemotherapy for his mesothelioma. And this is a picture of him with a tube coming out, which we connect to a bottle here. And this is a picture of it dressed. So it's indwelling pleural tunnel drain. And this is how it comes by negative suction to drain the fluid off. So that is just a bit of telling you about what we do lately. Right, so just to summarize with pleural effusions, we've done a few definitions and the importance of the fact that we need to know what the cause of it is. We talked about unilateral, bilateral, we talked about exudate, transudate. We've talked about the classification according to Lice criteria, and then classification according to causes. The management we've talked about, and I've mentioned indwelling pleural catheters very briefly. So I have come to the end of my talk, and I'm happy to take any questions.
Hi, any questions? Anyone of you?
Yes, I'm here. I don't have any questions, but the only thing I was interested in, you know, when you said you insert the tube, the thoracotomy tube or something?
Yeah.
Is that done via the mouth?
No. Which one are you referring to? This one?
I think it's the one done under general anesthetic, the video assistant.
Oh, no. It is all done percutaneous. So, for example, if you had this patient, what they'll do is that they'll put you under general anesthesia, lie you on your left-hand side, with the fluid side up, and they'll put 2 ports through your skin over there.
Gotcha. And is there a particular position that you go in, like, for example, between the 3rd and 4th intercostal space,
no,
just depending on the pleural effusion?
You have complete control of the field. Okay. It's in a controlled environment, so there isn't. It is in pneumothoraces that you have to specifically go through a particular area. But for pleural effusion, the lung is far away from where you're inserting the drain, so it doesn't always matter as much.
Okay, perfect. Thank you very much.
Hi, I'm with Nathan here, and we were just wondering if you could run through the lung cancer staging again, just because I couldn't quite catch like the graph and like how that quite like worked out.
Okay, I'll do that.
Hiya, yeah, thank you for the talk. Similar to what Pedro said, just like some clarification on like the TNM and then the newer stuff that you use to classify it.
Okay, so T is size of tumor. So this is still used significantly, but T is size of tumor. So T1, T2, T3, T4. Yeah. If the tumor is less than 3 centimeters, is T1, 3 to 7 T2, 3 greater than 7 T3, and if it invades the local structures, such as the heart, etc., is T4. Yeah, but this is just a cartoon that is being used. Okay. Now the lymph nodes, there's no lymph node involvement at all. So this is a tumor. The black thing is our tumor. If there's no new lymph node involvement and this is the tumor and this is the midline. The dot here is the midline. So tumor, midline, tumor, midline, tumor, midline. If there's no lymph node involvement, then it means it's T1 N0, and if there's no metastasis to other parts of the body, M0. To T1 N0 M0. It means it's got a very early cancer, and you can offer operative surgery to get totally get rid of the tumor. Yeah. Now you can sometimes have T1 N1, but I'll come to that in a bit. So the lymph node involvement, if there's no lymph node involvement, is 0. If there's a lymph node involvement, these are the green things here, the lymph nodes. Lymph node involvement on the side of the tumor, it is called N1. It's ipsilateral. If there's lymph node involvement at the side of the tumor and in the mediastinum at the side of the tumor, is called N2. If you have lymph node involvement at the side of the tumor as well as beyond in other lymph nodes crossing the midline, then it's called N3. And then if you have no metastasis outside the chest, it is called M0. If you have metastasis or bilateral lesions, it's called M1. Or if you have a malignant pleural effusion, it's called M1. So T, N, M. Now, depending on which combination of T, N, and M, the combination you get is what determines your staging. Yeah, so the combination of what you get in adding up the T, N, M, M is what determines your staging. Now, if you have stage 1 and stage 2, then it means you can almost be offered curative surgery. If you have stage 3, stage 4, curative treatment, stage 3, stage 4, you cannot be offered curative treatment. Does that help?
Hi, yeah, that was great. Thank you.
Okay. Now,
yes, thank you.
Was the
that helps.
standard form we used to use, but International Society for Lung Cancer now have come up with a slightly different staging. So this is just T1, T2, 3, T3, 4, and then M and not M1. Yeah. But here, if you look at this, we have M1A, M1B for the M staging. The T is divided into T1A, T1B, T2A, T2B, and they have reduced the sizes from 3 centimeters to less than 2, 2 to 3, 3 to 5, 5 to 7. So they've changed the sizes slightly because research and retrospective analysis have shown that the smaller your tumor, the better you do in the long term. So that determines how aggressively people should offer surgery. So this is the current accepted classification, but we still revert to T1, T2, T3, T4. But the classifications for lymph node involvement is still exactly the same. And this is the International Society for the Study of Lung Cancer. All right.
Yeah, that's great. Thank you.
Okay. Thank you very much for listening. I hope you found it helpful. Any Gita, am I okay to log off?
Yeah, that's fine. Thank you, Osei. Thank you very much. Thanks.
Bye.
Yeah, thank you. Bye-bye.